Hi, good evening, viewers. Welcome to another episode of Health Talk with Dr. Mo, a show where we keep it real, relatable, and rooted in facts. Remember, we promised that we'll always bring something that is worth your while. And today is no exception. We have with us an amazing doctor, someone I am so happy who is joining us. And he is no other person than Dr. Daryl Crenshaw. Dr. Daryl is a compassionate nephrologist. He's based in Thomasville in Georgia. He has nearly 2 decades of service. He's known for his dedication to improving health outcomes, especially in underserved communities. Born in Selena, Alabama, he's also a respected educator. He serves as a clinical professor of medicine at Florida State University College of Medicine and clinical faculty at Philadelphia College of Osteopathic Medicine. Wow. He has held historic leadership roles as the first African American chief of staff, and later the first and also the chairman of the board of the Archbold Memorial Hospital, guiding the institution through COVID-19 pandemic with his lovely wife, Brittany. Nationally, he chairs the Embark Awareness Subcommittee of GlobalCon, advocating for awareness of genetic kidney disease, such as the APOL1 mediated kidney disease. His work has earned him numerous awards, and he remains grounded in faith and family and service. Please join me as we welcome Dr. Daryl Crenshaw. Welcome, Dr. Daryl. It's nice to have you on the show.
Dr. Moji, it's an honor, and thank you for having me this afternoon.
Thank you. So, Dr. Daryl, we're going to be talking about kidney health. Kidney health is something that there's a huge gap in it globally. And like I always say, it's one of the things that it's like we're sitting on a time bomb, you know. And if nothing is done, we're going to have a lot of problems in our hands. And, for me, the why it is so significant is the effect it has not just on the patient himself or herself, but on the family, on the burden, on even the society. I say to people that kidney disease, apart from cancers, is one disease that can make a millionaire a pauper in a few months. Said so, it is something that we need to really, really, really look into and see how do we tackle this. And from your expertise, I mean, I was very impressed at the fact that the genetic predisposition of CKD, which is not often known or even discussed, is one of your expertise. So first of all, let's look at it. What exactly do our kidneys do, and why are they so important?
Absolutely, Dr. Moji. The kidneys have several functions, but simplistically, the kidneys are responsible for cleaning our blood. Every minute, our kidneys they filter waste, toxins, and extra fluid out of our bloodstream. And so that's one of the primary functions in conjunction with removing fluid. This is what keeps us in water-based balance in our bodies. And so the kidneys has those two primary functions, but then they also help regulate salt and potassium and various acids in our bodies. And then, another function of the kidneys is that they help us make very important hormones. Hormones that control our blood pressure, hormones that actually produce red blood cells. And then also hormones that keep our bones strong. And they do that through the maintenance of vitamin D. And so in summary, in short, those are the primary functions of the kidney.
Wow. Okay, thank you. You said it all. So how common is kidney disease, and why is it often called a silent condition that kills?
Well, it's actually one of the myths, when people say that they feel fine because their kidneys are healthy. And what's really ironic is that, 90% of most people who actually have kidney disease, they don't really know they have it. It's actually very common. And many times, up to about 70 to 80% of the kidney function may have already been declined in a patient or a person before they actually start developing symptoms. So
Wow.
kidney has that notion of being somewhat of a silent killer. When you look at the prevalence, though, Moji, of kidney disease globally, about 850 million individuals have kidney disease
Mm.
globally.
Yeah.
And right now, it's around the 14th leading cause of death globally. But what's interesting, it's projected to move up to about four or fifth by
Wow.
2040. So we see that there's a huge gap in the recognition of kidney disease around the world, not just in the United States, which is where I reside, but globally. Because when you look at places around the globe like Africa, Africa carries about on upwards to a 18% prevalence of chronic kidney disease
Mm.
in that continent. And so when you look at kidney disease globally, it is very, very prevalent. But the unfortunate thing is that the majority of individuals who actually have kidney disease don't know they have it yet. So that's very
Wow.
unfortunate. And so it means, Moji, we have a lot of work to do
Sure.
with diagnosing kidney disease around the globe.
Wow. So, talking about diagnosis, how can kidney disease be early diagnosed?
It's a very
Because,
good question.
yeah, because
Go
one
ahead.
of the issues that I've seen, even while I was practicing and even working in pharmaceutical, is the fact that patients come in very late. So, what are the things that needs to be looked out for from the part of the patient and also from the part of the doctor as well?
That's a wonderful question because part of diagnosing kidney disease actually starts out with very subtle signs that the patient can miss. And this can include Moji, unexplained fatigue and low energy. Certainly if individuals start having swelling, primarily in the legs, but oftentimes in the face, those are signs. What's a
Okay.
very unique sign of kidney failure is certainly if the blood pressure is out of order, and it's very unique that the blood pressure starts remaining high on a persistent level. And
Mm.
then when you get into the severe kidney disease, another sign that can be missed is loss of appetite, oftentimes nausea, and then it's not uncommon to even have some metallic-like taste that can be present. And another kind of feature that patients may miss is foamy urine, because foamy
Mm.
urine may imply that this may be a sign of protein in the urine, which kind of goes into the hallmarks of what we start as clinicians and nephrologists begin to test for kidney disease. And we can do that primarily through two ways. One is through the blood work, whereby we can check a level or what's called a creatinine level. And we can use that to calculate a glomerular filtration rate or a GFR. But then also too, we can look in the urine, Moji, to assess the urine primarily for protein. Protein is one of the most identifiable markers for kidney disease. So if we see
Okay.
protein in the urine, then we have to be on alert. And I like to educate patients on that because
Mm.
there are often times where the lack of recognizing protein in the urine can be a problem, and patients can have protein in the urine for decades and not have it recognized. And then once they start seeing the creatinine rise, then now it gets picked up that this patient may have
Right.
underlying chronic kidney disease, and
Wow.
oftentimes the pathology or the damage to the kidney has already been done. So,
Mm.
so I think the recognition of that from the patients and also from providers being more vigilant in checking the creatinine level and the protein in the urine is so important.
Right. Oh, wow. I mean, it's interesting to know that simple tests such as checking the protein in the urine can alert you to say, okay, and you know, I think most people don't ignore when they're urinating to know whether it's even foaming because um if I remember well, there's some times where you ask a patient and do like, did you by any chance see foam in your urine? And they're like,
Mm-hmm.
oh yeah, 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 yeah. That's a long time. Then I just drank a bottle of beer. And so I expect my I expect my urine to foam because they just had a bottle of beer. So looking at Now looking at, I mean, just what you said now, what are the things people need to look out for in their urine for them to say, you know what, I need to go see a doctor now? Because now is a wake up call that we need to start looking at our urine each time we pass urine to give us even an alert that say, okay, something is going on here.
That is an incredible insight. And you're absolutely right, because oftentimes, even before the laboratory studies reveal any evidence of kidney disease,
Mm,
you may often see very subtle findings. For example, a change in the coloration of the urine. It's not uncommon that the urine may have a darker color, or
mm,
more
oh,
impressively, you may start seeing signs of blood in the urine. And certainly, when there's
mm,
blood in the urine, or the urine has a tinge of blood, or even a kind of a hue or a pinkish color to it, that may
yeah.
be an early marker that kidney disease may be present. And so certainly the coloration of the urine, the frequency of the urination. So,
Frequent.
particularly if someone is saying that they haven't urinated in a long time, or if they're having, frequent bouts of urination, these can all be other signs that the kidneys may be playing a role in this. And so
Okay.
these are questions or concerns if a patient is going to the bathroom multiple times at night or during the day, etc.
Mm-hmm.
These may be early markers too. And then obviously, if there's any changes when it comes to foam in the urine, or even oftentimes there may be other indicators. For example, if your urine has really a brownish texture to it, Moji, oftentimes this may be an indicator that not only the kidneys may be playing a role, but there may be underlying other organic damage, such as liver disease.
Mm,
So
mm,
the urine, being able to appreciate the quality of the urine, I think is
yeah.
so important. And having that
Got it.
appreciation can not only pick up on various kidney diseases, but other systemic diseases as well.
Wow. Wow. I mean, that's very insightful. Thank you, Dr. Daryl. So, what are the common causes of kidney disease that you've seen in your practice?
Well, we know that the three major kind of the trio would be: number one globally is diabetes.
Diabetes. Mm,
Diabetes is number one globally, and then the second cause of kidney disease globally is hypertension. And so
mm,
those two lead to a combination, or the kind of the triad. The third would be a combination of diabetes and hypertension. And
okay.
so that is very important, because when individuals have both diabetes and hypertension, the progression of kidney disease can be multiple folds times
Mm,
faster, or in progression. And so really appreciating that right off the bat is so important. And again, not in conjunction with the, I would say, the underappreciation of kidney disease from a global
yeah.
perspective, we're still having an underappreciation of hypertension and diabetes and
Yeah.
metabolic syndrome and all these other conditions that may be playing a role with what leads to ongoing kidney disease.
Mm, mm, mm. Wow, that's right. I mean, just talking on that, something just came up to my mind now. What is the role of obesity in kidney disease?
It's 100% a major, major role, Moji.
Wow.
And what's been fascinating is that for several decades, numerous studies, including a study that I conducted at Emory over 2 decades ago, looked at the correlation of obesity and kidney disease. And even back then, we're talking on upwards 2.5 decades ago.
Mm,
What the data revealed even then was that patients who had higher degrees of obesity progressed faster towards needing dialysis. In other words, their kidney
mm,
disease got worse based on a higher BMI. And so we knew
wow.
that for the last 2 decades or more. That's been well identified. But
Mm,
what now has been really appreciated is just the converse, is that now with weight loss, and particularly in the setting of severe obesity, that individuals that
yeah.
can lose weight has been identified as individuals that could potentially mitigate or reduce their risk for kidney disease and actually improve their kidney function to some degree. So what has been
Yeah.
really appreciated now is that obesity is a huge has a huge impact on the progression of kidney disease. And so this
Wow.
is why right now it's being incorporated in our therapies, the use of GLP-1 agonist therapy,
Yeah.
and also gastric sleeves and other types of surgeries to try to minimize the significance of obesity. And so appreciating that really has given us more of appreciation to what obesity means to chronic kidney disease
Right.
around the globe.
Wow. Thank you so much, Dr. Daryl, for that. Huh. So, what are the everyday habits that we engage in that harms our kidneys the most?
It's a very good question. I think we've kind of touched on a few of them. One is certainly our dietary habits leading to obesity. I think obesity now is probably one of the bigger drivers of chronic kidney disease
Yeah.
globally, because even now in countries where there had typically or historically was not a prevalence of obesity, but due
Mm.
to the unfortunate kind of the globalization of the Western diet. In other
Yeah.
words, high fatty content foods that are high in carbohydrates, leading to high levels of obesity. We've seen in other places around the globe where obesity is, there's a higher prevalence of chronic kidney disease
Mm.
in those areas. So I think our dietary habits and then consequently where there's high or levels of obesity, you can deduce that there is a reduction in exercise and
Right. Yeah.
other therapies as such to try to burn calories and lose weight. So we're seeing that is being one of the bigger drivers. But also we have other things that could be playing a role as to why we see or higher rates and certainly certain degrees of kidney disease. One of
Mm.
the areas that I'm always fascinated is in particular in our area of the country is the utilization of medications that are over the
Mm.
counter, such as nonsteroidal
Yeah.
anti-inflammatory
Yeah.
drugs. We understand that those medicines can also play a role in further impacting chronic kidney disease and making it worse to some extent. And so I think those are some of the things when we look at obesity, when we look at the ongoing rates of hypertension, diabetes, and then now the appreciation of certain medicines that may be adverse to the kidneys. I think all of those are kind of some of the major factors that we have to be concerned about as to why kidney disease is so prevalent.
Oh, wow. It's a lot. There's a lot to learn about the kidneys, honestly. uh, so, how much water should people really be drinking for healthy kidneys?
So historically, we've always said about 8 ounces of primarily water per day. Although I can be liberal at times because many times people and my patients don't like to really just consume just plain water, and so I
Yes.
like to say that if that's the case, then what I do endorse, Moji, is a water-based beverage.
Okay.
And water-based beverage with, if they want a sweetener, then the primary sweetener I recommend and I use is stevia or stevia extract. I don't
Oh,
really endorse the other, what we call the artificial sweeteners.
sweetness,
Uh,
yeah.
so I try to stay away from those. But if they want
Okay.
something that's natural, then I tell them, a water-based beverage. And there are several on the market that now incorporate stevia as their sweetener. So
Okay.
I'm a big fan of that if they want to utilize those beverages. Because here in the South, and this is kind of the caveat, is that the South is very, very, the southern part of the United States rather is it has a very kind of subtropical climate. And so I really have to endorse them to drink because if they get behind on their fluids, particularly Moji, if they're taking diuretics
Mm,
and they're losing excessive water,
water, yes.
if they're in these climates where they're
Mm,
not consuming water, then
water. Yeah.
unfortunately they can develop acute kidney injury, which then
Yeah.
can portend into chronic kidney disease. So I
Mm.
really want them to have their volume of fluids again, primarily in the form of water or a water-based beverage.
Oh, okay. So now I have a bottle of what in this part of the world we go in mils. So this is a 500 mils of water. So um How many of this, really? Because
So,
I
you
want to
know,
be practical enough.
yeah. So about four of those.
About four of this.
Yeah.
Okay.
Yeah.
So if I
About,
drink a cup of tea, if I use this, half of this to take, if I take tea or I take Ribena, I take great tea on, is it counted as me hydrating my kidneys? Because honestly, some people like myself, I don't find water really interesting to drink.
uh,
Sometimes it can get nauseous drinking just water.
yeah.
And then I hear things like my husband is like, you have to drink water, not colored water. It has to be water. So if I drink colored water, 500 mils, have I done well?
Correct. Well, you know, you asked about tea, Moji, and I always like to, even my patients, because I'll ask my patients, as I did this morning when I see them, I always ask about their
Yeah.
beverage content. And
Okay.
and the first thing, as um, most people do for the majority, they start out their day with a cup of coffee. And
Yes.
I always
Yeah.
have to be cautious about that because of
Yeah.
the caffeine intake.
Inside. Yeah.
So I always like to say that co- any caffeinated beverage, like perhaps tea or certainly coffee,
Yeah.
unless it's decaffeinated. But I have to be careful because the diuretic effects of the caffeine in coffee can be
Mm,
counterproductive. So I like to always
right.
say that for every cup of coffee they're drinking, to make sure that they're drinking, going back to their water-based beverage,
Okay.
because what can happen is that they can actually have more urinary excretion due to the
Yeah.
coffee intake, and some people drink 2 to 3 cups,
Mm,
which can add up. You know, actually that can add up to almost a legitimate dose of a quality diuretic. Like
yeah.
in the United States, we use furosemide or hydrochlorothiazide. If you
Yes.
drink 2 or 3 cups of coffee, that can actually have the diuretic effect, and these patients can still be dry on the inside
Mm.
enough that they can actually start developing, acute kidney injury, leading to
Oh
some
God.
form of chronic kidney disease in the long run, potentially.
Wow.
So, that's always been that thought. The other thought too is, and it's been a little bit of a debate over time, is, you know, do you have to really drink the classic amount of water per day? And because some of the thought is that if you're ingesting the right amount of vegetables, which vegetables, we all know, fruits and vegetables are majority water, but there have been thoughts
Yeah.
that, yeah, if you eat enough fruits and vegetables, you're actually getting enough of your water intake per day, that you
Oh,
don't have to physically drink water. So that's always
nice.
something else to think about. For
Nice.
example, we love watermelon, I'm a big fan of
Yeah.
watermelon, and a lot of
Yes.
people in the South are. But watermelon is about 80 to 90% water. I mean, it's literally, so when you're eating watermelon, you're literally getting your volume intake that you need to get in. So
Mm.
that's the other thing to consider too when
Hey.
you're trying to assess for your water intake.
Oh, that's comforting. That's quite comforting to know. Sometimes you need the variety to just make sure that okay, I'm not doing badly. I'm not doing
Correct.
badly. Thank you. Thank you so much for that. So we're going to be talking about myth busting. One of the aims of this show is also to debunk myth that people have had over the years and try and educate them better on it. So, um, herbal detox teas cleanse the kidney. Do kidneys really need detoxing?
That's very good. And the answer is yes, they do. And guess what? They actually get a wonderful detoxing through water intake.
Okay. So,
So,
herbal teas,
teas, yes, absolutely.
herbal teas are fine. Okay.
Yes, 100%. I'm a
Oh,
big fan of herbal teas.
okay.
But I think naturally, and this is where I like to keep it yet simple on how God made us. He made
Mm,
us that water is really the primary agent that we really need for our detoxing and cleansing agent.
wow.
Not just for the kidneys, Moji, but from the gastrointestinal
Mm,
system, for our all of our, pretty much all of our cells, the billions that we have, our neurons, all of them do wonderfully if we incorporate the right amount of water on a daily
what?
basis.
Yeah.
It's
Yeah.
a wonderful detoxing agent.
Nice. That's good. Okay. Second myth that we want to bust is dialysis a death sentence?
The answer is no. No, it's not a death sentence, and dialysis has saved many, 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 many lives
Mm,
over many decades. Dialysis is a wonderful modality as far as that measure alone. Let's be clear. We like to say if the kidneys don't work, dialysis in the modern era does a very, very good job of
mm,
replicating what the kidney should do. And it's those things that I mentioned earlier about cleaning the blood and removing excessive fluids and correcting, our electrolytes and our acid base
yeah.
disorders. It does a wonderful job of that. Now, however, um, we as clinicians and nephrologists, we have this kind of this paradox with dialysis that we hate it but we love it because we understand that when a person gets on dialysis there are other
Mm,
comorbidities that they start developing, and one substantial comorbidity that they develop is cardiovascular disease.
mm,
And so we understand that yes, when a patient is on dialysis and has the definition of end-stage kidney disease, they by definition have some underlying elements of cardiovascular disease. Matter of fact, cardiovascular disease is the majority of the time it's the reason why patients on dialysis pass away. They
mm,
pass away from some type of
mm.
cardiovascular
Yeah.
event. So we're very cognizant of that, and
Okay.
as a result of that, we understand that yes, dialysis has a tremendous amount of benefit. It's really no controversy behind that. But at the same time, what dialysis does remind us is that we need to be very proactive with our patients and
Right.
our culture to really do what is possible to diagnose chronic kidney disease earlier,
Yeah.
but then also to maintain that adage, Moji, that an ounce of
Mm,
prevention is worth a pound of cure. And so,
mm.
getting back to the basics of daily um, uh, exercise habits, daily
Yeah.
habits of watching what we eat, daily
It,
habits of reducing
mm,
obesity,
yeah.
daily habits of maintaining good blood pressure, good blood glucose control, all of those things can definitely have been shown over time to definitely reduce the risk of developing severe chronic kidney disease to
Mm.
require dialysis.
Wow. Wow. Thank you very much for that. Now, the one that is actually very dear to my heart. Tell us about the genetic cause of CKD, because I know this is one of your expertise, and quite a lot of people don't even know that you can get CKD from having a genetic predisposition, either from your parents or from your family. So please educate us about it.
So over time, Moji, it's been wonderful in the space of nephrology because what we've now begun to recognize is that many of the diseases now in kidney regarding kidney disease has some underlying affiliation with genetic predisposition. And
Mm,
we've really become more aware of it, but it's become a fascinating part because now we recognize that perhaps for the last several decades, there have been individuals and certain ethnic groups who may have been uh, misdiagnosed as far as relating to what we like to say the misattribution of kidney disease primarily to hypertension and diabetes. And we still
mm,
appreciate the fact that those are the two leading causes of kidney disease globally. But when we start looking at various kidney disease, we have many that are very, very rare. Conditions like Alport syndrome, Fabry's disease, these are very rare conditions. But when you get into the more prevalent causes of genetic kidney disease, when you talk about polycystic kidney disease, that's one that's
mm,
more prevalent. But one now that is really now kind of hit the forefront of genetic related kidney disease is one that is called APOL1 mediated kidney disease. And it's a very unique disease because it actually got originated in sub-Saharan Africa.
wow.
And we understand scientifically when we talk about APO1, the APO1 gene, we inherit an APO1 gene from one from our mother and one from our father. But what has been recognized and what is fascinating about this gene is that in sub-Saharan Africa, having variants of this gene actually prevents those in sub-Saharan Africa from developing African sleep sickness. So it's a protective benefit in sub-Saharan Africa. It's fascinating. But what
Wow.
has also been identified is that if there are variants, in particular what we call the high-risk variants of this gene, in
Okay.
individuals that have two of the high-risk variants, particularly in the Western world, has been recognized that there is a predisposition to chronic kidney disease.
Mm.
And this involves individuals who have some degree of African ancestry. And so what we have identified is that any individual who has an underlying history of some African ancestry who carries these two high risk variants, 1 in 5 actually develop risk for chronic kidney disease. And
Mm.
so what we have now appreciated is that there has been somewhat of a misattribution of chronic kidney disease to hypertension. And remember, I said earlier that hypertension has
Yeah.
always been appreciated as one of the leading causes of chronic kidney disease, particularly in people in the United States and African Americans. But what we're recognizing now is that some of that misattribution may be related to APO1 mediated kidney disease. And
Mm.
so it's a wonderful time. And even as of today, I had a patient in my office who came to me from another state because he was concerned about chronic kidney disease, which he had always been attributed to hypertension. We had what we call hypertensive nephrosclerosis.
Okay.
And when we reevaluated the patient and worked the patient up, which included genetic testing primarily because he had a mother who had underlying chronic kidney disease that was also attributed
Mm.
to hypertension. And
Wow.
so now we have at our fingertips wonderful testing. We have a genetic test that we can do
Oh,
literally by the swab of the cheek. And there are other tests that are out there that are wonderful tests,
oh,
which
nice.
have multi-gene panels where you can test for, polycystic kidney and all other variant types of genetic kidney disease. But for this
Okay.
particular test, it swabs particularly for the variants of APO1 mediated kidney disease. And so, sure
Right.
enough, this is what he had. He
Right.
has the two high risk variants. And so, what we
Wow.
were able to tell this gentleman is that no, some of this may have had hypertension. Okay, because
Mm.
what we're recognizing is that yes, again, 1 in 5 develop chronic kidney disease, and what's now being appreciated is that there's what's called a second hit to those individuals who have two high risk variants that ultimately have chronic kidney disease. So, in other words, you can have two high risk variants, but not necessarily develop chronic kidney disease as a result of that. And
Oh,
so
okay.
we are appreciating the fact that there is some other hit like COVID-19 virus
Yeah.
or like HIV or like some
Mm.
other affiliated illness
Needed.
that
Yeah.
that turns the mechanisms on for those two high risk variants to develop and transition into chronic kidney disease.
Oh, okay.
So we are now appreciating that. And what's beautiful now is that we're at a space that now we can bring closure to a lot of these patients because Moji, what's happened is that
Mm.
many of these patients have walked around forever thinking that it was their fault. They're walking around thinking that yeah, it was because of what I ate or what I did.
Yeah.
It was that my high blood pressure and I didn't keep my
Guilt
blood
tripping
pressure under control.
themselves. Yeah.
100%. And so
Mm.
now we're able to say, no, this is a genetic predisposition. So now that they perhaps can go and tell their other family members that, hey, I have this condition, you may need to be tested too.
I see. Okay. So, I mean, that's splendid explanation. But I want to find out at what age do you want, I mean, are people tested for this genetic predisposition?
So ideally, in an idealistic situation, the earlier the better. Because
Okay.
because if we can catch it, what has been identified, Moji, is that individuals who have two high risk variants for APO1 mediated kidney disease transition to worse kidney disease at a much faster rate.
Oh,
So the sooner
okay.
we can identify these patients, the sooner we can be very aggressive on the full end to treat them and get them on therapies to reduce the pathologic causes of kidney disease in relations to
Yeah.
APOL1 mediated kidney disease, which is a
Okay.
pathologic condition called focal segmental glomerulosclerosis.
Okay. Okay.
So that is the condition that is so when a biopsy is done of a patient with APOL1 mediated kidney disease, the vast majority of the time, that's the pathologic correlation with that gene expression is that you get focal segmental glomerulosclerosis,
Okay.
and there are therapies that we can go ahead and initiate on those patients on the forefront to
Mm.
reduce the further damage to the area of the kidney that's involved, which is what's called the
Yeah.
glomerulus. That's the filtering system of the kidney that's
Okay.
responsible for all the damage that leads to
Yeah.
further chronic kidney disease in these patients.
Mm. Spot on. So, is there a particular age where we need to screen? We should start. Do we screen children for this genetic predisposition, or they have to get to a certain age before they're screened for this disease?
So that's really right now the biggest debate in our country right now is how
Okay.
aggressive we screen, and right now we're developing a lot of advocacy from a
Okay.
professional standpoint. This is what one of the coalitions that I'm so grateful to be a part of. It's called Embark Awareness, and this is what we're doing. We're bringing more awareness to this disease around the country,
Right.
and we're going in high risk areas again, particularly in places where there is a high burden of individuals with African ancestry.
Right.
Emoji, I want to be clear, African ancestry does not mean African Americans only. It also
Mm.
implies Latinos and any individual in the Western world that may have some underlying African ancestry. So this may
Okay.
imply Hispanics. This is
Mm.
individuals from places like Cuba, Colombia, Mexico, Venezuela,
Mm.
Brazil, all of these areas, we're seeing more prevalence of APOL1 mediated kidney disease because we understand
Wow.
the linkage of African
Yeah.
ancestries in these parts of the world. And
Mm.
so we're in the United States right now. We're very very aggressive with establishing professional groups to go to high risk areas and to do
Okay.
genetic testing.
Testing. Okay. That's
And so
good.
that's what we're doing. We're going
It's
to
really good.
places around the country to
Mm.
get high risk testing. And I just conducted a health fair in my area where, I mean, it was jam packed, and we actually found people who had
Wow.
perceived normal kidney function, by the way.
What?
And but ultimately, when we tested them, they had the two high risk variants for APOL1 mediated kidney disease. Now, mind you, when we tested them, we do a preliminary test looking for protein in the urine, and they ended up having that. But again, these individuals were asymptomatic, no symptoms at all, feeling fine, feeling great, living their lives. And if you had to do a questionnaire on them randomly, they would say, "I have no
That's it.
kidney
I'm
disease at
fine.
all."
Yes.
But when we
Wow.
tested them and we saw protein in the urine, that allowed us to have the initial spark. Remember, I said when protein in the urine is one of the earliest manifestations of kidney disease. We took that to the next stage and tested them for APOL1 mediated kidney disease, and they were positive.
Mm, mm, mm. I mean, just talking about what you said now, it sparked something in my head. And I'm like, okay, do people really have to go to the hospital to test if have protein in the urine? There should, I know that there used to be strips, protein strips that you can use at home. I'm just trying to see how we can reduce the burden of people going to the hospital very late. Because just like you said, I mean, the person feels fine, the person no, and of course, having protein in urine is not something that is symptomatic like headache, that causes you
Mm-hmm, mm-hmm,
discomfort.
mm-hmm.
And as human beings, until we get that discomfort, we don't action anything. So is there like or I mean, how do we get people or do a mass, is it a mass campaign or something that we have to say, okay, you have to check your urine protein, urine for protein, maybe every 6 months, every day,
Mm-hmm.
something people can actually use
Mm-hmm.
at home, you know? to just do like a quick check, and they don't have to go to the hospital, wait on the queue for a long time for laboratories and all that. I mean, is there something like that you think can work?
Oh, absolutely. I think from what you're saying, it's very insightful from the standpoint you could go right now and go to Amazon if Amazon is available and buy a set of test strips.
Okay.
You can actually do your dipsticks at home. And certainly this is being extremely proactive, which I am a big fan of. And you can go and do your dipsticks at home. And if you see protein in the urine, which is very readable and very easily interpreted, then that can give you the next no, the notion to go to the next step and go to the doctor and say, hey, doctor,
Yeah.
I actually did a strip at home and it has protein in the urine.
Yeah.
Then that could be the early stages. I think
Okay.
that is something that I think for an audience like yours, I think that would be very insightful and certainly will not be surprising just based on the prevalence of chronic kidney disease. You can guarantee there are going to be individuals that have protein in their urine, and like myself and
Definitely.
other nephrologists,
Definitely.
they've seen
Yes.
protein in their urine and then
Yeah.
not have any symptoms. Again,
Mm.
when you have protein in the urine, many of these patients are totally asymptomatic.
Most times,
They,
almost to
they,
90%. Yes, you're right.
they feel
You're
fantastic.
very right. You're very right. You're very right.
So I
So,
think that's a very
yeah.
proactive way right off the bat.
Yes. Yeah.
And what that does is that you now you take onus on that and you can
Mm.
now go to the next phase and make sure that you're healthy and then make sure your family's healthy.
Exactly. So, viewers, you heard it from Dr. Daryl. You can buy the strip from a local pharmacy, or for those that are in the Western world, you can get it on Amazon. You can save yourself the stress of presenting late kidney disease by just doing your urine protein. You can do it every 6 months. You can do it at least every 1 year, at least. So that is the barest minimum. And I'm sure it doesn't cost an arm and a leg to get one of these test strips, because you'll really be saving yourself a lot of things. And honestly, thank you so much, Dr. Daryl. And just two more questions, which is like an insight from you. You've said so much. So, what is one thing that every one of us can change today to protect our kidneys? What is the message you have for each and every one of us?
That's a wonderful question. I think it's one word, and that's proactivity.
Mm,
Think proactivity, just being aware that what we talked about today, certainly the two leading causes of kidney disease, high blood pressure and diabetes. So the
mm,
first thing off the bat, make sure your blood pressure is controlled. Make sure
right.
you're not at risk for diabetes. And I would even go a step further that even now being more sensitive that even if you're a pre-diabetic, that's something to consider. So I think those are the two things. And then the proactivity to just understand that a healthy diet,
Mm,
daily exercise, and
sides, yeah.
drinking the right amount of water will probably, amen, will probably solve about 95% of the problems. Here's
Yeah,
the beautiful thing is that if you're already doing those things, it's the beautiful thing going back to my patient today who had the two high risk variants.
yeah.
The beautiful thing about him was that he was already proactive.
Oh,
So he
mm,
has two high risk variants for APOL1 mediated kidney disease, but he was already watching his blood pressure. He's watching his weight. He's exercising. He's doing all the right things. And guess what?
mm.
His kidney function right now is very stable.
Wow,
So I think,
nice,
again, the
nice.
proactivity to do the right
Mm,
thing is so important. Proactivity. That'll be my word for the audience as far as what we can do to uh, to avoid at all possibility of developing chronic kidney disease.
wow. So you've heard it from Dr. Darrell. You have to be proactive. You have to be intentional. You have to take it into your health is your wealth. There is no gambling about it. So I hope you'll be proactive and check your urine this week. So what is the kidney related mistake you wish more people avoided?
I think that's a very good question too, because I think when you say the kidney related mistake, I think it's somewhat somewhat intuitive to the proactivity is I would say the lack of proactivity. I think that's
Mm.
the thing, especially now with the fact, Moji, we have access to resources, we have access to information, we have access to knowledge. You know, what's really impressive is that many times now the patients, when they come to me, many of them know the terminology of chronic kidney
Yeah.
disease. They've heard about
Yeah.
it. They know about chronic kidney disease. They're telling me, well, doc, I don't have diabetes, I don't have
Yeah.
hypertension, so I want to know what is my causing my kidney. So
Yes.
they know these things.
Yeah.
But I think now understanding that and appreciating that they understand this knowledge,
Mm.
that they could take it to the next step and be more proactive.
Proactive. Wow.
And
That's
if I had to say, I would say a little bit of apathy,
mm.
and apathy as far as watching their diet, apathy as far as not, getting to the gym or just going for a walk a few times
Oh.
a week. All of those things, I think,
Mm.
are some of the things that I would probably be a little more. Um, it makes me a little sad from time to time that those
Mm.
things are not being pushed a lot more.
Okay. Oh. Wow, it's been an exciting time. It's been very insightful. I've learned a lot talking to you. Thank you so much, Dr. Daryl. I mean, I called in a short notice and you answered me. I'm so grateful. And on behalf of our audience, we say thank you. I said this is what we call it a wrap. And of course, dear audience, you've learned a lot. It just takes you to be intentional and proactive, just like Dr. Daryl said. The amount of money you would spend to prevent kidney disease is no way near what you will spend if you have kidney disease and you even progress and you have to have dialysis. I always say it, prevention is the cheapest form of medicine. Yes, doctors want to see you, but of course, they are always happy if you come to them healthier than they even want, they think. So this is what we call it a wrap. Thank you so much. Thank you, Dr. Daryl, and hope to see you again to have more discussions on kidney because I know it's a huge, it's a huge topic, and there's so many aspects of kidney and kidney diseases and all that. But because of time, we want to release you, and we really, really appreciate you for your time and for your expertise. Thank you so much, Dr. Daryl. All right.
My pleasure.
So, yeah. So, this is what we call it today. Remember, health is wealth. And if you found this insightful, please like, share, subscribe. You might be saving a life. Thank you and bye.